Thank you very much. Again, it's a pleasure to be here. And I'm going to try to move through a little quickly because I know there's the event this afternoon that we all want to attend. I'm really looking forward to the band to hear about the Brazilian rock music. So I'm going to be talking about improving perioperative patient safety. And I wanted to put this in the framework of these goals that we have. They're called the National Patient Safety Goals. And these are put out by the Joint Commission, which is an accreditation body in the United States. I'm going to talk a little bit about how these goals can be looked at within the context of perioperative care. The first of the goals is to identify patients correctly. And this one, we still run into problems, but as we were talking about in the safety checklist examples that I used in my earlier talk, one of the big things is that there need to be multiple people confirming the patient's identity, site, procedure, and consent for this procedure, and that you need two sources of ID. This is involved both with pre-procedural checklists, it's involved in checklists for administration of blood, for hospitalizations. In fact, oftentimes in the United States, if you're calling up your doctor's office to make an appointment for any sort of doctor's office, they ask you your name and they ask you your birth date in order to try to provide on a verbal level two sources of ID. Now, another factor in this national patient safety goals is that of improving staff communication. And this is communication between doctors, nurses, handovers, and these type of things within the operating room. For instance, I run the Anesthesia Closed Claims Project, which reviews adverse outcomes and risk management reports and malpractice claims. And looking at claims that have come in the since 2001, what we find is in reviewing this, 43% of these have some kind of communication failure involved. When we look at what the problems are, these include things of issues with intraoperative events and preoperative informational and medical history. So these type of problems could be dealt with by closer adherence to the preoperative safety checklist. And that includes a formalized discussion of what I consider good care of what the critical events during the surgery are. Now, when I work, I'm a neuroanesthesiologist. I know my surgeons. I know when the events are. But when I'm on call and I'm working with urologists who I may not work with much, I may not really understand when the critical events in their procedures are. These events could include things like the blood loss, the length of the surgery so you can make a plan, the fire risk so you can shut off your oxygen when the cautery is being used. And they include from us to be able to communicate formally with the surgical team about what our concerns are, the patient, difficult airway, concerns with problems that if we do get into blood loss, how much blood do we really need? What's the likelihood of this? Communication concerning postoperative outcome and disposition. And then just our general process measurements that we use in the operating room, including warming, glucose control, beta blockade, antibiotic prophylaxis to prevent infections, and venous thromboembolism prophylaxis. And you could be sure in the ARS protocols that we not only do we have guidelines that we can print out, but the surgeon also and anesthesia team communicate over those particular ARS issues. Now, what other problems we see in the closed claims database with relating to patient injury? And these include in blue, as you see, the postoperative care plan and patient status changes that may arise, such as in the recovery room after they've left the operating room or early on in the intensive care. And in order to try to come up with better means to deal with this, there are a variety of mechanisms, particularly checklists for transfer out of the operating room, and team training and checklists or protocols, and oftentimes computerized things that get transmitted to ICU and to PACU. Now, what kind of problems do we have? Well, in the typical situation, there's an inadequate transfer of information. I mean, especially in the operating room, I see the senior surgeon leaves, the junior surgeons, many of them change off from the surgeon, the more senior resident in the surgery to the intern. The interns are on 12-hour shifts and they go home. And then there are inconsistent or incomplete teams in transfers, so that you may go to ICU and never talk to any of the surgeons. We have inefficient and absent protocols, so that we don't really know, with everyone doing things differently, what will really happen, and there's poor standardization. So these kind of checklists can then help in this, and we talked about in my earlier lecture about the sign out or the transfer of care component, and that you see in the blue that the discussing with the surgeon, the anesthesiologist, and the nurse in the operating room, who then now goes and talks to the nurse in the recovery room, your key concerns for recovery and patient management in the recovery room or on the floor or in the critical care unit. Now, what have been recommended in order to improve handovers? Well, one of the items is to standardize the process. These include checklists and they include protocols. So in my institution now, we have a button you push on the computer and it basically self-populates from the anesthetic record and from the patient's preoperative and medical history, things that will then go to the critical care unit or to the recovery room, and it's just pushed by button and goes through the computer system and appears, and that the anesthesiologist picks it up and uses it to discuss with the nurse along with a surgery representative from surgery. Now, you also, when you look at these kind of handovers, you often see people chatting about the football game or chatting about what they did on the weekend, or they're really busy with working and trying to connect the monitors. So you wait till the monitors are connected, and you get rid of these non-patient discussions until after the handover is done. Likewise, all the team members need to be present. For our institution, trying to get a surgery resident to go to ICU was impossible. Now it's required. It is a protocol set up, it's standardized, they have to go. If they don't go, they get into trouble. They are counseled and then get into trouble. And then we need to have training in team skills and communication. Especially a lot of work has been done in the emergency departments and in the obstetric units. These are ones where there often is people, I think, teams that aren't working together as commonly as you may have teams within the operating room setting. Now, do these handoffs really work? Well, there was one study done at Boston Children's Hospital, and it was published in JAMA in 2013. And they instituted in 2 units in this hospital a handoff bundle intervention among their residents. They had a training session. They had a mnemonic to help the residents remembered it. And in one of the units, they actually have a computerized handoff tool, which when you have enough, ultimately not all of our hospitals have this kind of computer support, but if you do, it is a very nice thing. And they developed a uniform team approach. What they found over here is that before bundle, if you're looking at the number of medical errors made per 100 admissions, They were about 35, and they went down after institution of this bundle. And that preventable adverse events also decreased after the institution of the bundle. These kind of things are very important because we all transition in care to other people. In particular, in the residency programs now, many of the residents are on 12-hour shifts. Some come in and are just there at night, and so there are many more handovers than there used to be when I trained. And that is because of the effects of sleep deprivation on performance and learning that this has now happened. Now, another thing in the safety goals is preventing infection, and I think most of this results in the operating room setting is timely administration of antibiotics and in use in central venous catheters using sterile technique. And I think we'll be seeing more and more about other ways in the future that we in anesthesia can reduce infection. This article is now 10 years old. I think we all have used these bundles basically to reduce catheter-related bloodstream infections in the critical care unit and in the operating room. The American Society of Anesthesiologists in 2012 set up some practice guidelines relating to this, and it also looked at things relating, besides infection, to prevent mechanical trauma or injury. These kind of preparations in terms of use of chlorhexidine, sterile burials, which are including hat, mask, sterile gloves, sterile gown, covered body by a sterile drape, and are really critical to a use of reducing bloodstream infections. And I think in the United States there's been a massive change over this period of 10 years as pretty much everyone has universally adopted this. There still may be complainers and laggards, but they are adopted now. The American Society of Anesthesiologists central venous catheter guidelines also looked at use of ultrasound for internal jugular venous insertion and recommended it. They recommended it for both to identify the vessels as well as to be able to confirm in cross-section that your wire was truly in the internal jugular vein, and to use some other techniques such as manometry or pressure waveform monitoring rather than just relying on blood color in order to look and make sure that your final catheter is going into the jugular vein rather than into the carotid artery, and to check the tip position postoperatively. Now, the fourth measure that the National Patient Safety Goals have is one of using medication safely. And medication errors are prevalent in our specialty and in medicine overall. We do administer medications, and it's basically 1 out of 130 anesthetics. There's some kind of medication error, albeit most are often no harm arises. When the type of errors that you can see, they can include wrong dose or wrong drug or wrong route or wrong time. They also can include an omission, such as failing to give the antibiotic prior to starting the surgery because you're so worried about the patient's medical condition, or accidentally giving a drug twice or more, a repetition. When you're looking at these kind of errors, they can include individual or system errors. On the individual side, there are a variety of factors that go into this. Fatigue, stress, inexperience is often a big issue. A stressful patient, oftentimes at night, that's a big issue. These are individual events. But the system events are really a big problem. I'm not sure how it is in Brazil, but in the United States, our hospitals change their little vials very frequently. I'm sure when I come back after being away a week, I will have new vials there. And they look alike. They have small print. One may be a bigger vial, now suddenly is a small vial. And oftentimes there's very poor organization. This is one that we had in our hospital. It's milrinone and neostigmine. Exactly the same size vial. The milrinone was placed by the technician in the neostigmine section. Failing to read it or failing to check a barcode, as we now have technology to do this, could have led to a problem. Fortunately, it was picked up. In the closed claims database, we find that most of the medical, or half of the medical errors are substitution, basically, and incorrect dose. Substitution means you actually give a drug such as phenylephrine instead of metoclopramide or ondansetron. They were both in small vials, they looked alike, they changed frequently in the colors. Or incorrect dose, often an issue in pediatrics. So how do you prevent these medication errors? Well, I think the best way is now if you can use preformed syringes and pharmacy preparation. So for instance, we no longer have phenylephrine in the 10 milligram vial because at least twice a year it was given often on OB floor where the patient's awake instead of ondansetron. So now we have it in a bag, in an infusion. The pharmacy makes it. We now have devices available that are barcoding. They're called Codonics. I don't know the company. I didn't see it in the hall, but we have the ability now to self-label and to check the barcodes. And we do this now because we had a lot of serious drug errors. However, I'm older and I feel more comfortable just checking multiple times at each step that I'm giving a drug. And that's how I learned, but I think some of the younger people really do benefit by the technology, and in times of stress and fatigue, it may be helpful as well. Final goal of the National Patient Safety from the Joint Commission is to identify areas of high safety risk. And I think one of the areas in the operating room deals with the treatment of emergencies. Now, working in trauma center, you may have patients have a cardiac arrest and die very frequently. Perhaps during open heart surgery you do as well. But if you're doing lists of the average kind of patients, even high-risk patients, having a cardiac arrest intraoperatively is a rare event. I hadn't had one for a patient who had a cardiac arrest for years, and about a month ago, which fortunately for me was about 2 weeks after I finished my ACLS recertification, so everything was in my mind, I was very able to quickly know what drugs to give and to resuscitate this patient. But I'll tell you right now, especially after time in Brazil, and I'm going to the beach, so I'll totally forget it, there you have the emergency manuals. And Stanford has been very big on these kind of things. Now, this study in New England Journal, which is done primarily by surgeons in Boston, we're actually looking at simulated operating room crises. And they were looking at checklists and if you use them versus not in the resuscitation of a patient. And those where a checklist was used had fewer of these, they had fewer failures of adherence to critical events. In other words, they made fewer errors. In contrast to without the checklist, it was often easy to forget a critical step in the resuscitation process. And these include things, they occurred both in following advanced cardiac life support measures and also in following hemodynamic instability in that. So at least in the simulation laboratory, they've been able to show that these type of things can be helpful. And you can have them as cards, such as this. Stanford University has these type of things you can download, you can laminate, put on your anesthesia machine, or if you have computer capabilities, you can develop it to appear on the computer. Push a button and it will appear at the time, and then someone can check off these kind of checklists and make sure you're following things. So in summary then, making errors is human. We all make mistakes, and we're trying to improve patient safety overall in medicine. That I think checklists, communication, learning how to communicate, technologies and ways to reduce medication errors and use of emergency manuals can be extremely helpful. Thank you.